We'll have after the last presentation questions. Invite Dr. Mohan to talk about contact lens dispensing tips.
Good morning, everyone. I thank Dr. Chandrasekhar and Professor Viavri for giving me this opportunity. The topic given is contact lens dispensing tips. I think it will be useful for the practitioners also. So, the indications for contact lens, the highly motivated patient and a high refractive error, that is more important. And we'll have to go through the types and materials of the contact lenses, selection of patients, accessories which are needed at the clinic, and the time to be spared. Selection of patients is a motivated patient and anisometropic patient. We'll have indications later. Accessories, the routine refraction set which you have in your clinic is more than sufficient. Along with that, a keratometer is better equipped. And then if you want a selective range of patients for higher contact lenses like ortho K or other lenses, we need to have a topographer. And more important is the time to be spared, because you need more time to spend with these patients to motivate them for fitting and then for post-fitting methods. The advantages in the contact lens is the initial, in fact, comfort, but for some it might be a little bit of discomfort, watering will be there. You will have to reassure the patient, and fitting will be easier if you sit along with the patient other than the optometrist if you have time. And you will have to talk about the advantages of occasional wear and change of color of the eye and less chances of lens being dislodged which the patient might be having. The soft contact lens indications are optical, therapeutic, preventive, diagnostic and cosmetic, and some occupational also. Contraindications, you will have to select the patients accordingly. A poorly motivated patient, it's better to leave them alone, and some inflammation around the lid, dacryocystitis, blepharitis or chronic conjunctivitis, it's better to avoid fitting contact lenses. And in case of dry eye syndrome also, it's better to avoid. And in case of corneal degeneration and dystrophies. And some idea about the low water content, the high water content contact lenses. The advantages, low water content is less susceptible to the environmental changes, and which has a low protein deposition, and it's easy to manufacture. Disadvantages is a low decay value is the water content of the contact lens. High decay value, it's more flexible and faster restoration of shape is there, but the disadvantage will be the fragile, lower tensile strength and more deposit prone. This is the FDA classification for decay and decay by T values. T is the thickness of the contact lens. The higher decay by T value, the thinner the contact lens. Types of contact lens, there are disposable contact lenses, daily disposable, 2 weekly disposable or monthly replacement. It's a simple cleaning method which is used, and latest designs and materials, and it's more popular. And then there is the extended wear lens made from silicone material. Colored contact lens, handling tint. High myope patients will be having difficulty in locating the lenses during wear, so tinted lenses will be better for them, and it's useful while inserting and removing the lenses also. The materials which are used in the contact lenses are HEMA, hydroxyethyl methacrylate, polyvinyl alcohol type, and N-vinyl polyolidine. Advantages of soft contact lens, again comfortable and well tolerated. The materials of silicone contact lenses, silicone with hydrogel lenses. Technical names are as mentioned above. The soft contact lens types: spherical, aspherical, toric and multifocal. So each type has got different advantages. A spherical soft contact lens bends slightly and evenly in every direction, and typically used to correct myopia and hyperopia. Aspheric contact lens have varying curvatures across the surfaces, changing from the edge to the center of the lens, and different interaction between the light and lens entering the eye, and makes a clearer image. This is the FDA classification of the hydrogel lenses. Advantages of the silicone hydrogel lens: more resistant to protein deposits, higher oxygen permeability, flexibility, and its good wettability also. Disadvantages: if there is going to be a little bit of astigmatism, the visual acuity will be decreased, and there is a lower rate of oxygen transmission, and it's more fragile. And next, coming to toric soft lenses. different focusing power at the vertical and horizontal meridian is present in this, corrects astigmatism. Additional design characteristics prevents the lens from rotating away from the required alignment. And there are some markings also in this. Fitting guidelines. First you will have to select the lens type and then determine the lens power, total diameter selection, base curve selection, and the trial fitting. So, and how do you select the selection of the lens for the patient? Evaluation of the patient with the help of a slit lamp, tear film evaluation, systemic evaluation, and the expectation of the patient and the financial condition of the patient also is more important, along with the occupation and wearing time. It also depends on the diffraction, whether a patient is going for only a spherical or a toric or a gas permeable. And the comfort and visual acuity is also the first priority. And selection of the lens diameter is by horizontal visible iris diameter, which is evaluated with the help of a transparent rule which is placed in front of the eye, and you can take a calculation directly, and you will have to add 2 millimeters to the measurement which you have taken, so that the lens covers the complete cornea. How do you select the base curve? Base curve selection is from the K readings which you have evaluated previously, and usually the K reading will be flat, medium or steep, as accordingly less than 41, 41 to 45 or above 45. And the base curve for soft contact lens will be specified as steep, median and flat, depending on 8 to 8.3, 8.4 to 8.6 or above 8.7. And the power selection will be manifest refraction, which you have done previously with the vertex distance conversion. I will talk about vertex distance later. If there is going to be a plus cylinder, you will have to convert it into a minus cylinder by transposing. And the patient's refraction should be the spherical equivalent in some cases. For astigmatic correction, you may need a toric lens. How do you determine the lens power? If, example, the subjective refraction is -4 with a -1 cylinder at 180, the spherical equivalent can be given. And because it is 4 diopters, you will have to go for a vertex distance compensation. This vertex distance compensation, you got a chart, you can take it from there. And what is the spherical equivalent? If the patient has got a mild astigmatic power, you can take a half a cylinder of the power from the astigmatic correction and then add it to the sphere, and that becomes a spherical equivalent. If the cylindrical power is less than 0.5 diopters, you can ignore and you can just give the spherical power only. And if it is between 0.75 to 1, you can take half the power of the cylinder and add to the spherical component. And if it is more than 4 diopters, then you will have to go for the vertex distance correction. Because why we will have to take for a vertex distance correction? The distance between the spectacle from the cornea is different, and as the lens goes nearer the contact lens, it changes. The contact lens is nearer the cornea, whereas the spectacle is away from the cornea. There are 2 methods. The simple method is the method to add half of the cylinder to the sphere, and you will have a calculation table. You can get the power directly, as mentioned in the last thing. You need not go to the theoretical aspect of that. After fitting, you will have to look for the corneal coverage. It should be adequate. When the eye is in the primary position, the full cornea should be covered and should have at least 1 to 1.5 millimeters away from the cornea all around. If it is greater than 2 millimeters, then the lens is too large, and if it is less, the lens is too small. You will have to fit accordingly. And it should be equally centered in all directions beyond the limbus. How do you evaluate the fit? Allow the contact lens to rest on the eye for 5 minutes before evaluating the fit. Lens centration after each blink should be evaluated, and you can check the visual acuity after the contact lens has been placed on after 5 minutes. If there is no movement, then the lens is too tight. If there is excessive movement, it's too loose. And the visual acuity should be stable whether before, after the blink. Signs and symptoms of the steep fitting lens: fluctuating visual acuity which clears after each blink. Then you'll have to correct accordingly, which I will mention later. In a flat lens, before blink, the patient's vision is better, and after a blink, the lens gets decentered and the vision becomes dull. And in case of a steep lens, patient will have a blurred vision before the blink, and after the blink, patient will have a good vision. How do you modify this? If it is going to be a flat fit, tighten and decrease the base curve, but keep the diameter the same. So it will be inversely proportional. And if you are going to increase the diameter, keep the base curve the same. And opposite is the steep fit. The signs and symptoms I already mentioned. Visual acuity is unstable with each blink. Patient awareness of the lens, the foreign body sensation might be there, and because of the poor centering, there will be low fitting and lens might move to one place. How do you modify? If it is too large, decrease the diameter, but remember the decreasing diameter may inadvertently affect the base curve. And recheck your modification with the trial lens. You should have a trial fit ready. Complications of contact lenses: GPC, corneal abrasion, erosion, contact lens lens acute red eye, keratitis, ulcer, neovascularization. But all these are because of the handling of the patient. Suppose if the patient is going to commute for a long time, at least 2 hours, and they use the lens when they step out of the house, they tend to sleep if they are not going to drive. And later on, they end up with a little bit of a corneal opacities. And then they'll have to stop using the lenses. So usually change the pattern of the application of lenses. Once they go to their office or the college, they can use the lens there. Conclusion: use patient interview to determine the lens type, and the ocular examination to evaluate the base curve, diameter, and the power of the patient. And you should have a trial lens set to evaluate the lens fit. And you will have to take the visual acuity and over refraction if the visual acuity is not what was expected. Make any modification to the fit, and use trial lenses to evaluate modification. Explain the insertion, removal, care and handling and cleaning to the patient. Because if it is being deputed to somebody else in the front office, we have seen patients using the lenses for 6 months without removing the lens throughout. And then they come back with a severe corneal edema, and then they'll have to use just glasses in spite of the treatment given, and the visual acuity also suffers because of that. The final order of the contact lens should contain a base curve, the power of the lens, the diameter, water content, tint, material, manufacturer. This is for theory. But outside, for prescription, we can have a base curve, power mentioned, and anyway we are going to talk about the tint, whatever is necessary for the patient. The base curve ranges from 6 to 11, but most are between 8.4 to 9. The power range is also different. Decentration, I already talked, late decentration, early decentration, and unstable visual acuity. And in cases of RGP lenses, discomfort, lens edge might be too thick, and excessive movement, it's too flat. The same thing. Deposits also should be taken care of. The lens care products should be concentrated on, because usually they won't change the lens the solution in the lens case. So it has to be mentioned to the person and highlighted it. The best disinfectant is a hydrogen peroxide. At times it can be used, or change the lens, but examine the lens under the slit lamp if possible, if the patient gives any complaints regarding that. Since time paucity, we can have the different other type of contact lenses available: bifocal contact lens, cosmetic and prosthetic lens, orthokeratology, therapeutic contact lenses, keratoconus contact lenses in children, and miscellaneous. Orthokeratology is a different type of lens where you have reverse geometric curve lenses, which is used during night time, and the patient is removing the lens in the morning. And usually the pre-LASIK patients are better for the orthokeratology lenses. One advantage is that. The second advantage is it can be handled by the parents instead of the children. So the visual acuity is maintained throughout the day, and the next day, in fact, for some patients, once in 2 days they use their orthokeratology lenses. It's a rigid lens. There are first generation, second generation, third generation lenses which have come, but in between only plain myopic patients can be corrected with ortho-K lenses. At present, there is a toric ortho-K lens which is available very recently. We are not sure about the effects of that. And complications for ortho-K lenses is very minimal. In fact, we haven't seen any complications as of now, other than the breakage of the lenses because of the handling. Therapeutic contact lenses will be used usually in cases of in case of post-keratoplasty patients, because it's a plano lens and it can be used for 1 month at a stretch, and it can be changed after 1 or 2 months accordingly to the patient's comfort. Keratoconus, again, you have different types of lenses, which is out of this purview, piggyback lenses, hydrogel lenses, and other lenses. With this talk, I thank you for